Hey, thank you. Well, welcome everybody from across Canada and indeed other parts of the world. People are still signing on, so I haven't seen where everybody is coming from yet, but I know generally we have people from outside of Canada watching too. So welcome to all of you. Uh, this webinar today being presented by CARP is Hope and Challenges for Lung Cancer Today. My name's Bill VanGorder, and I'm the Chief Operating Officer and the Chief Policy Officer for CARP. I'm going to be the moderator for what promises to be a very interesting season. We've got some wonderful expert panelists representing both medical professionals and patients, and I'll introduce them shortly. But want to talk a little bit about the webinar itself. We're doing it on November 1st because this is the start of Lung Cancer Awareness Month. As the title implies, we'll be using our time to look at both some good news about lung cancer, which we hope will provide hope to many people, as well as we'll be talking about some of the challenges that face us, especially in the struggles in the wake of the pandemic. At the end of the discussion, we'll answer some questions you might have. So please feel free to submit those questions on the chat button. And Anthony, do we have the slides up and running?
We will have in 1 minute. I'm going to share my screen.
Yeah, I'm going to wait just a moment to so we can catch up here.
Can everyone see that?
Yes.
Okay.
That's good. All right. So let's just slowly go to slide 4, but we'll look at the other. We can skip that one quickly. There we are. All right, good. And at the end of the discussion, we're going to answer any questions you might have. So please feel free to submit them whenever you wish by using the chat panel, as Anthony said. You do so by clicking on the chat button and writing your question. You'll find the chat button generally right in the center bottom of your screen. Now, the chat's being moderated by Anthony Quinn, our CARP Chief Community Officer, and he's going to bring those questions forward to me. So if you want the questions to be directed to a particular speaker, please say so. So let's get started with some of the facts. The facts remind us of the seriousness of this topic for all Canadians and our health. Lung cancer is the biggest cause of cancer cases and deaths in Canada. It will be diagnosed in about 30,000 Canadians this year and will account for almost 1 in 4 cancer deaths in Canada this year, about 20,700. Sadly, more Canadians die of lung cancer than colorectal, pancreatic, and breast cancers combined. Those statistics are rather grim, but we do have a word of hope for you on the next slide. By the title of this webinar is good reason to say hope and lung cancer together. We'll talk more about this with our guests, but here are a few reasons we think there's hope in lung cancer. First, lung cancer screening programs are now available in 3 provinces, British Columbia, Ontario, and Quebec. As with other cancers, more screening means more diagnosis of lung cancer at an earlier stage when it's much more treatable. And new treatments are allowing more people to live longer. The mortality rate for lung cancer in men has been declining substantially since the 1980s. From 1991 to 2007, it declined 2% per year, and since then has dropped 2.8% per year. The mortality rate for women has also been declining for 15 years since 2006. So with more screening, new treatments, and ongoing research to better understand cancer, there is real reason for hope. The next slide will show us that along with hope, there's also some serious challenges for us discussed today. First, the big one is the stigma surrounding lung cancer. Second, screening programs are great, but they're only available in 3 provinces. A lot more needs to be done to make these programs available to all Canadians and to encourage their use. And if you agree with this, I urge you to get in contact with your local elected representatives in the provinces that don't have them and tell them you want screening available in your province. Third, there are many promising new treatments that take just too long to get to Canadian patients. And finally, one of the big challenges for lung cancer today is the one faced throughout the health system. How could we catch up with the backlog created by the pandemic? Well, that's enough from me. We want to get to our panelists. We've got a lot of interesting aspects to discuss, and I'm pleased to introduce them. First of all, Dr. Stephanie Snow. Stephanie's the president of the Lung Cancer Canada. She's a medical oncologist at the QE2 Hospital in Halifax. John Peter Bradford is the CEO of Life Saving Therapies Network, a patient-led network of experts that works to enable patients with lethal diseases to have faster access to the best therapies. He himself is a throat cancer survivor and was a caregiver to his wife who died of lung cancer. And certainly not last but not least is Andrea Redway. She's a lung cancer patient and a strong advocate for lung cancer patients in Canada. So thank you very much to the three of you for joining. It's wonderful to have you with us today. Our discussion will focus on 4 areas. The next slide will show us catching lung cancer earlier, revolutionizing how we treat lung cancer, ending the stigma, and addressing the COVID backlogs. But before we get started, I'd like to ask Andrea and John Peter to tell us a little bit about their own experiences with lung cancer. Andrea, let's start with you.
Well, thank you, Bill. I was diagnosed with lung cancer in 2015, and it was quite a shock to me. I was 47 years old and had no known risk factors for lung cancer. And the only sign had really been a cough for a few months. And then I started having other symptoms. So I went to the doctor and, a few weeks later found out that I had stage 4 lung cancer that had already spread to my brain, my bones, and my adrenal gland. So it was a complete shock. And I had young kids at the time, and it seemed like a very hopeless situation. But luckily, I had access to some new treatments, and that made all the difference, which I can talk about more later in the program.
Good. Well, thank you. And Dr. Bradford, what about you? What was your experience?
Well, it was an experience of being a caregiver to my wife, who had none of the normal things that you would associate with. She never smoked. She was healthy. She ate healthily. She ran. She didn't live in a radon-infested basement. She was just like the picture of health. She never sick. And then one day she was making a birthday cake for me, and she fell down in the kitchen. She had been saying she was tired for the month before, but she'd been working hard. So we thought that was just because she was working too hard. And the next day, she woke up and she couldn't make it to the bathroom. I had to carry her into the bathroom. And we took her eventually to the emergency room. And 12 hours later, they said, you have stage 4 cancer. You probably have 3 months to live if you're lucky. Stage 4 cancer, they didn't know the lung at that point. And so she had been my caregiver when I had throat cancer, and I'll be drinking a lot because I have no saliva. So this is my saliva in the bottle here to keep my mouth wet. And so long story short, we basically got her 4 experimental drugs, 2 of which were not even in trial yet. She lived 15 and a half months before she died. Her life totally changed, but she had what she called a simple, happy life. And basically I did nothing but take care of her, get her drugs, and that was my job, 24/7. Best job I ever had in my life, actually.
Well, thank you both for sharing those stories, and I think it really puts these issues in perspective. So I'd like to start with the discussion now. Maybe Dr. Snow, a question for you first, because as with other cancers, we know that finding it early, it really improves the opportunities for a good outcome. But we don't hear nearly as much about screening for lung cancer as we do about breast cancer and colorectal and even prostate cancer. So can you give us a kind of a brief overview of what the screening involves, how it helps find cases, and the general process with screening?
Absolutely. That's a great question, Bill. And before I start, I'd really like to thank CARP for organizing this. I can't think of a better day or a better way to kick off the first day of Lung Cancer Awareness Month, which of course is November. So lung cancer is a disease that meets those basic criteria for a disease in which screening is a good idea, because you have to have three features. It has to be a common disease. It has to be a disease that's important to find, like with a significant health and mortality burden, and it has to exist in what we call a preclinical stage. That's a time when the patient has no symptoms, but if you detect and diagnose during that time, it can be treated for cure. Now, there's now multiple trials that have been done in tens of thousands of patients around the world that have shown that lung cancer screening using CAT scans leads to better survival. Other tests, including X-rays, have not been shown to be effective as a screening tool for lung cancer. So we use CAT scans to screen, and the primary goal is to find lung cancers when they're small at an early stage and can be treated for cure. And we know that this does save lives. For instance, if you're treated and diagnosed with a stage 1 lung cancer, your chance of being alive in 5 years is usually between 70 and 90%. Whereas the rate of survival for 5 years for those diagnosed with a stage 4 lung cancer is 10% or less. An important feature also of the screening programs is they're more than just screening for cancer. They're more of a lung health check, and they provide really special resources and supports for those patients who are current tobacco users to help them quit. And the impact of this may actually end up saving more lives as a prevention as opposed to detection, and not just for lung cancer, but for heart disease, stroke, and COPD, and many other diseases. Now, in terms of what it looks like, back in 2016, the Canadian Task Force on Preventative Healthcare recommended a low-dose CT scan annually for up to 3 years for patients who are between the ages of 55 and 74, who are either current or former tobacco users and had used the equivalent to a package of cigarettes a day for 30 or more years. Since then, we've gotten even better at identifying the best patients to screen. And as each health jurisdiction, most of which are provinces, are rolling out their own plans for lung cancer screening, the more sensitive criteria are being used to find those patients at highest risk. And those criteria may differ a little bit depending on what province you live in or what area you live in, but generally they're targeting patients between 50 to 55 to 70 to 79, and who have an approximately 1.5 or 2% risk of developing lung cancer within the next 6 years. And while history of tobacco use is still a major driver, there are other important factors that have been identified, including a history of COPD, a personal history of lung cancer, or a family history of lung cancer. And depending on the criteria and where you're coming from, the cancer detection rate will ultimately be about 6 to 15 cases per 1,000 CAT scans. And to put that into perspective, the cancer detection rates for breast cancer using mammograms is about 5 cases for 1,000 tests. Now, you and your primary care provider don't need to worry about figuring out your own individual risk to see if you're eligible. If you may be, all that needs to be done is have a referral sent to your local lung cancer screening program if there's already one set up in your area, and the program will figure out your risk and follow up with you.
Okay, well, that's very interesting. Andrea and John Peter, you both live in Ontario, a province that has availability for screening and more availability. What's your suggestions of what people should do if they think they may be at risk of lung cancer? And Andrea, maybe we'll start with you.
Well, obviously they should talk to their family doctor and talk to them about their concerns and see if they're a candidate for it. You know, a lot of people are very hesitant to recognize their symptoms or go if they feel they only have some sort of mild symptoms like the cough that I had. So you really have to pay attention to your body and not be shy about going to your family doctor to advocate for yourself and get the screening that you may well need. We know that actually almost 50% of lung cancer patients get diagnosed at stage 4. So it's really important to get in there as soon as you feel like there may be an issue.
Okay, good. John Peter, anything to add to what people should do in provinces where screening's available?
Well, I should tell you, I just want to tell you one thing with my wife. She had actually had an X-ray a year before she was diagnosed, and she and her doctor concluded that it was just a scar from childhood pneumonia, when in fact it was the cancer. So I just want to echo what Dr. Snow said about the appropriate kind of screening tool. My view is, I guess, a little bit more radical than Andrea's. I think it should be like a pap smear or an annual or semi-annual colonoscopy or every 2-year colonoscopy, depending on what your risk factors are, and that everybody should be run through them, because the savings to the system would be so great. And not to mention, I hate systemic thinking, not to mention how important it is for the quality of life of people, that they're going to have better or full lives and so on.
Right. Okay, understood. Dr. Snow, lung cancer screening is only available in BC, Ontario, and Quebec at the moment. So what about those of us who live in all the other provinces who think we may be at some risk for lung cancer? There's no formal screening program yet. So what can we do? What can the rest of us do? And you and I both live in a province that doesn't have it yet.
Yeah. Well, hopefully coming soon. Most provinces, at least, are in the process of putting forth a business case or getting ready. So there's a lot of work going on behind the scenes across Canada. Another important thing to remember is that screening is for people who don't have symptoms. So no matter where you live, if you have symptoms, shortness of breath, cough, those things, you should seek out medical attention, as Andrea said, and the diagnostic or investigations are available no matter where you are. But in terms of true screening of asymptomatic patients or patients who don't have symptoms, if there's no program where you live, there may be a pilot project or even a research trial for which you may be eligible. So it's worth asking. There's also a certain degree of what we call opportunistic screening going on. So that's when, for instance, a lung doctor, such as a respirologist or a pulmonologist, recognizes that a patient does meet the criteria for lung cancer screening and will order a screening CT outside of the confines of a formal screening program. Now, that's certainly best care for those particular individuals, especially when it's ordered in the right patient with the right risk factors, but it's less desirable, obviously, than an actual screening program because it doesn't often reach those who are in the most need and at the highest risk for lung cancer. And there's no built-in way to make sure that the required follow-up from that scan will happen. And so opportunistic screening is not a replacement for an actual CT organized program, because it's complicated with multiple annual CTs, and also making sure that the appropriate referrals are made if somebody needs a biopsy, needs to see a surgeon, those types of things.
We also now want to talk about revolutionizing how we treat lung cancer. And one of the things I'm curious about, Andrea, is about the treatments you received and the role that research and innovation played in your case.
Right. Well, so when I was diagnosed, first-line treatment for advanced lung cancer was still chemo and radiation, which I received initially. But after about 6 weeks, we knew that chemo was only partially working. There's some areas of improvement, some areas not so looking so good. And so I would not have, without research, I would not have had any other options really at that point, and I know I wouldn't be here right now. But I was very lucky that the clinical trials for immunotherapy for advanced lung cancer patients had just been published in the New England Journal of Medicine right around the time I was diagnosed. And so I was able to access an immunotherapy drug, and it has made all the difference. As I mentioned, I had multiple areas of metastases when I was first diagnosed, but after about 8 months on immunotherapy, those areas had completely cleared up, and my primary tumor had shrunk by almost half. So that was just a miraculous result. And then I continued on immunotherapy for about 2 years, and then I stopped treatment altogether for 3.5 years, which was amazing. And then in early 2021, I had some signs of the cancer starting to grow again. So I went back on treatment. Now, more recently, I've had some other changes. My voice has become strained and some other issues. And so we're looking at changing my treatment. And one of the great things is back in 2015, I sent my tumor sample away for testing at Foundation Medicine in the US and discovered I had a specific mutation called the RET mutation, R-E-T. And at that time, there were no treatments for that. And this is part of the whole world of personalized medicine. I had no options for that back in 2015. But now there are drugs available for that. There have been for about 5 years now. And so I have yet another really good treatment option available to me because of research. And so the research that's been done the last 10 years has made a massive difference. But before that, there hadn't been many changes to treatment for lung cancer in a long, long time.
All right. Well, Dr. Snow, Andrea talked about some of the new things that are available. Can you tell us a little bit more about the new cancer treatments that are available and how much they can improve patient outcomes?
Absolutely. So Andrea talked about the two classes of therapies that I use as a medical oncologist that have really changed the face of survival, especially for people with advanced or incurable lung cancer, but those are now moving into the curative intent setting as well. So targeted therapies, as Andrea mentioned, only work if you have a very specific target, and usually that is a mutation. And so part and parcel with that, you actually have to have access to the testing. So it sounds like Andrea sent away her tissue to America, but we're seeing more and more non-small cell lung cancer patients having access to testing here in Canada. And we really push that everybody should routinely be screened for those mutations. John Peter's wife had a different mutation called ALK. And so those targeted therapies have really led to much longer survivals. We have patients now who are surviving with incurable lung cancer into the double digits. And we find that for most of these targets, they're generally found in patients with a minimal or no tobacco history, and they're often more commonly found in women. And so we overall see significant improvements in survival in lung cancer rates. We're now up to 22% at 5 years in all comers, all stages, whereas in the 1990s, we were more around 15, 16%. But really, if you look at that group of non-smoking females who have that targeted therapy, their survival has gone up much, much higher. The other category of drugs that Andrea spoke about are immunotherapy drugs.
Right.
And immunotherapy drugs are fascinating. They don't actually target the cancer. They target and allow your own body's immune system to fight cancer cells. Now, we usually think of our immune system as fighting off viruses and bacteria, but we do have some white blood cells whose goal is to find and destroy cancer cells. But just like you can get pneumonia or a urine infection and your body can't fight it off, you need an antibiotic. Well, some cancers learn how to hide from the immune system and they establish themselves as tumors. And many of them do this by essentially creating a mask so that they can hide from the immune system. And what immunotherapy drugs do is they take that mask right off. So all of a sudden, those white blood cells that are there can now recognize the cancer as their target and really can have a profound impact in some patients. And my best patient, I think, started around the same time as Andrea, and she had widespread cancer, including in her brain. And she's been off treatment now since 2016 after about a year and a half of immunotherapy with no sign of cancer. Now, as a medical oncologist, I'm very biased. And of course, I really focus on drug therapies, but there are also a lot of newer technologies, both in the area of radiation and surgery. There are new radiation techniques where if people have a limited number of areas of cancer spread, they can treat them with what we call ablative therapy and often see very long survivors. And they can also treat some early stage patients for cure, patients who otherwise wouldn't be well enough to undergo the general anesthetic to have the curative intent surgery. So there are often patients who have, for instance, bad heart or bad lungs and can't have a general anesthetic, but they can still be cured with radiation. And finally, surgery used to be a big, big incision and lots of potential complications, but now they have fancy robotics and videos, and they can often, some of my patients are discharged from hospital after having part of their lung removed 1 or 2 days after their surgery, which is just remarkable. And so those make the surgical procedures a lot safer. So a lot of exciting things going on.
Well, that's wonderful news, but I wanted to ask you, John Peter, that new treatments are great, but how do people access them, or what are the challenges? Is it because obviously there are people that are not being able to be exposed to these great treatments?
Okay, well, this is a simple and a complicated answer. So I'll try to make it as simple as possible. Right now, the drug approval system in Canada, in particular, is got two streams to it. One is called the CADTH, C-A-D-T-H, Canadian whatever it is, technology, health technology thing, and then the regular one, which is so let's just stick with that one for now. If you go through that whole system, from the time a drug gets its approval, the drug approval process is only 180 days. It's 6 years before it gets to a patient. Now, this is outrageous, and there's no reason for it, except that the system is process-driven. Every time somebody wanted to, and it's safety-driven, and of course we should be safe. Regulations should be safe, but they shouldn't be cowardly. And they shouldn't have a feral fear of liability attached to them. And so we have one gunked up, terribly clogged, it's like a highway that you, instead of having an Autobahn-like speed limit where things are run sensibly, when it rains, the signs come up and say go slow, but otherwise you can just self-regulate. We have a system where every time there's something goes wrong in the highway, we put a speed bump in. We call it a process to help become more efficient. But what it does is slows things down. And pretty soon you have a long highway with a speed bump every kilometer. And so it takes very, very long time to get the drug approved. That makes the drug costly, way too costly, because every one of these processes and every one of these systems, and it attracts its own bureaucracy, it attracts its own everything. And so we have a much too complex and too costly drug system to get the drug from ideation, from the time somebody thinks of it, and gets it to the point where they can actually get tested to the time it gets to the patient is six years. So a rule of thumb is standard of care is not the best treatment. Standard of care is drugs that have already been approved, but the ones that haven't been approved, as Andrea can tell you, because she's sitting here, having taken ones that hadn't been approved before, are the ones that are going to work, and it's always going to be like that till we shrink this down. This down. The second thing is we have a number, as Stephanie, do you mind if I call you that instead of Dr. Snow?
Please go ahead.
Yeah. Okay. Thank you. The research protocols, excuse me for drinking, are out of the 1930s or 40s. Now, at one point I taught statistics and experimental design at the University of Toronto. So we used to teach that the best kind of experimental design you could have was what we called a randomized blocks design. That now gets translated into what medical people call the randomized clinical trial. It turns out that that is not the best way to do research for certain kinds of drugs. An example is this: when a drug called, I think it was called crizotinib at one point, it's now called Xalkori. Before that, it had a number like 783-29 or something. When it was first tested, it was tested in a big randomized trial with, say, just for example, 100 people. It worked on 3 people. And they threw those, so 3% of the people that were tested with it, it worked on. And so they threw it out as non-effective because they're looking for numbers like 45, 50, 60% effectiveness. Somebody in Boston, a woman researcher, said, I wonder what the genetic makeup of that cancer that the drug works on is. It turned out to be the ALK positive mutation. And it turns out that it worked on 91% of the people with the ALK positive mutation. But the randomized clinical trial, which costs a lot of money, takes a lot of time, has lots of people involved in it, uses a kind of statistics called inferential statistics, which are good for certain things, not others, missed that. And in fact, a lot of people died and suffered. A lot of high quality life years were lost because that drug was thrown out until somebody came along and thought, okay. So my general point is this: drug research trial protocols have to be tailored to the kind of drug you're testing. So now we have some movements in that area, and people are slowly moving in that direction, where they know that when you're looking at doing precision medicine, you don't need to have a big, although we still harp about this randomization, drives me nuts, but I guess I'm being long-winded here, Bill. The point is, we need clinical trial reform. The clinical trials, the experimental designs, and have to be altered to fit the kind of drug they're testing. We need to let real world evidence in and find ways to make, that is evidence that happens outside of these rigorous kinds of trials. We have to pay close attention to how people are included and not included in trials. There's a whole whack of things we have to do, but there's 2 areas in particular to answer your question. The first is the area of drug approval reform writ large, drug approval writ large. The one I didn't talk about is the PNPRB, which I don't want to get into because it's a mess. And the second is clinical trial reform and sort of broadening our understanding of what data are and so on.
You put that very, very clearly. Said, I know a lot of people are thinking, well, I agree, but what can I do? What can patients and their families do? What do you suggest they do to try to make these things happen?
Well, here's a book. This book is called Why Cancer Still Sucks. It's written by a world famous medical oncologist named Dr. David J. Stewart. Comes from Ottawa. This book is a primer for anybody who wants to know about cancer. It's written in a way that every chapter, there's a section for everybody, and then there's a section for specialists. So people who are in medical school or are interning or something, they can read the second part of every chapter. The first part is for you and me, the people that just need, well, more or less plain English. The last 3 chapters of this book are about what you can do. But what you can do is get angry, or you can not, be kindly angry. I mean, I'm all for kindness and love and peace, but you should not put up with the junk and the blather that is keeping drugs from people. In lung cancer, Stephanie will tell you this, with serious lung cancer, for every week of undiagnosed, of a lack of diagnosis, or don't forget that, for every week that treatment is delayed for somebody who has a serious lung cancer, 4 out of 10 people die. We just published on that in some oncology journal that I can't remember the name of, Dr. Stewart and I, and a couple of other people. But we have to get our voices, and we have to talk to the politicians, and we have to revamp the way we think about drug access, drug safety, drug approval. If I can prove to you that a drug is safe and you have a serious lethal disease, you should have the right to try it.
Right. Yep. Good point.
And we can build, it's easy to build theoretical and actual research vehicles that can actually capture data from that and make it all and build a body knowledge that makes sense.
Very good point. And by the way, we will put a link to that book and the information along with the webinar when we have the recording available to people, so people can look at it and get it.
The other thing, can I just say one other thing that I'll
yeah, sure.
The Life-Saving Therapies Network, which I'm the so-called CEO of, it was started by Dr. Stewart and I, the guy who wrote this book and who was my wife's doctor. We're dedicated to doing this stuff. So if people want to look at that link, if you could put that link up, and people can write to us, and we need a large chorus singing a lot of different kinds of music, but making the same point. Good,
we will do that. You mentioned, John Peter, the stigma. So I'd like to start with you, Andrea, because as someone who was diagnosed with stage 4 lung cancer, how was the stigma around the disease influencing on you and the people that talk to you about your illness? You know, what's needed to overcome to, we would probably all agree that stigmas aren't good, but this is a particularly difficult one.
It is, because we've all had the messaging for many years linking lung cancer to smoking, but there's actually at least 12 different cancers that are linked to smoking, if not more. And so it's somewhat unfair to put it all into the lung cancer world. I can tell you just quickly that my first experience with lung cancer was 20 years ago when my husband's uncle was diagnosed, and he died 2 weeks later. Nobody hadn't really known that there was a problem until it was too late. Then my mother-in-law was diagnosed in 2009, and she died 6 months later. And I can remember how much she withdrew after learning about her diagnosis. She really blamed herself. She felt, ashamed, I believe, because she wouldn't talk to her closest friends and her siblings even right after her diagnosis, because she just was at such a loss. And it really, in my own experience, I think the way I experienced it at first was through, of course, all the questions about your medical history involve smoking when you get started in the cancer system, and you repeat those over and over and over in different venues. And then, you're sharing the news with your friends and family, and that's the first question that comes up, if they don't know you well enough about your smoking history. And even when I went to look for a brochure in the cancer center about lung cancer, I remember looking at the rack. There were brochures about other types of cancer. The only thing on the rack was about stopping smoking related to lung, that was remotely related to lung cancer. So it's really impacted how people are treated, the empathy level they get from other people, the amount of research. And there is research from the Global Coalition on Lung Cancer that demonstrates this, that there's less empathy, that there's less money devoted to research because of the stigma. And also that means that there's fewer treatments, and that has had an impact on all of us, unfortunately.
Doctors, or John Peter, you had or have throat cancer. Your wife died of lung cancer. Did you notice any difference between the way people approached the two different cancers with the two of you?
I'm just trying to stop from telling a joke. The answer is not really, because my wife was a well-known non-smoker. She was a never smoker. She wouldn't allow cigarettes in our house. She wouldn't let cannabis in the house. She abhorred the idea of smoking. She thought it was terrible. 2 of our children smoke, and she wouldn't let them in the house until they didn't smell of the smoke anymore. So anybody who knew her did not really respond to her as if it was her fault, because that's what the stigma really boils down to. You caused this cancer.
Right.
A lot of people thought that my throat cancer was, sort of a God's comeuppance for all of my mouthiness.
Well, Dr. Snow, on the same note, Lung Cancer Canada, your organization, has launched a program called Stop Asking the Wrong Question. That's obviously on issue. Tell us a little bit about that.
Absolutely. So the first thing I wanted to say is this is not something we did on our own. This was a partnership we did with the Lung Health Foundation, which is another great organization, great advocacy group and support group for lung cancer patients and their caregivers across Canada. And we recognize together that the stigma is just so prevalent and has such an impact on our lung cancer patients. It's that concept of they did it to themselves, and it's very much linked to the concept of tobacco use. And at the end of the day, it doesn't matter if a lung cancer patient used tobacco or not. The only real risk factor for getting lung cancer is having lungs, and it's upwards of 20% of our patients that have never used or have very minimal use of tobacco. And it doesn't matter any more than we would say to a breast cancer patient, oh, did you use hormone replacement for your, menopausal symptoms, or say to a heart attack patient, oh, were you not that active and you ate a lot of red meat? And so our initiative was really trying to get people to realize that it doesn't matter if a lung cancer patient smoked or not. They still deserve the same compassion and care as any other cancer patient. So the wrong question is, did you smoke? And the right questions are, how are you doing? Or how can I be of help for you?
Great.
Here. Wonderful.
And how can we change the system?
Exactly. The final area we want to address today is the COVID backlogs. We know that COVID-19 has had tremendous impact on diagnosis and care. So I want to ask each of you about your perspective on where things stand now, and what do you think is going to happen, and what are you told by other patients you know? And Andrea, let's start with you.
Well, as you said, we know there was a huge huge amount of appointments canceled, screening programs stalled or put on hold, diagnostic tests, surgeries canceled, surgical procedures canceled, and this shift to virtual appointments. Of course, this has resulted, unfortunately, in such a huge amount of delayed diagnosis and people getting diagnosed at a much later stage. And they're just coming into the system more recently. And so we've got a very strained system where we're seeing emergency rooms being shuttered across Ontario and other parts of the country, and higher demand for services. So we need much more invested in more treatment options, diagnostics options, and treatment services for patients, because we need to give these people the service that they were unable to access when they really needed it the most, and that they're in dire need of now. And that, unfortunately, those investments don't seem to be coming. And then there's been the mental health impact, which has been huge. And that's really continuing today, especially with everything opening up more. But lung cancer patients and other cancer patients are still feeling very vulnerable and very, very unable to participate in all of the sort of renewed activities that are going on. It's very hard on the anxiety and isolation that people feel. And we need to, consider how we can address that and embrace sort of everyone in a return to normalcy that makes sense and makes everyone feel safe.
John Peter, what are your thoughts on the impact of COVID on patient care and what needs to be done?
Well, I think it's bigger than just COVID. The one thing about COVID is that it showed us that we know how to do stuff in a hurry if we really want to do it. And that attitude, that a lot of the things that have been done in COVID could directly translate into lung cancer and care for cancer in general, both on the preventative side and also in the treatment side. But more to the point, I think the system is already overloaded and broken. And there are just in Canada, just at one level in Canada, we don't have enough specialists, we don't have enough GPs, we don't have enough CAT scan machines, we don't have enough PET machines, we don't have enough MRIs, we don't have enough this, that, and the other thing. We're way behind. We're in fact at a level of a third world country in many ways compared to the one, Germany, for example, or the United States. At another level, the system is very, very inefficient. There's ways that you can streamline stuff, including the drug regulatory approval system and all that bureaucracy goes with that, but all other things about the way the system works you could streamline that and find money to make the system more efficient and make it more kind of immediate. You should be able to go in just like you need an oil change. You should be able. When I was a kid, I'm 80 years old. Probably Bill, a tad older than you, maybe, I don't know. But when I was a kid, you went to the doctor, the doctor saw you need a specialist, you saw the specialist that day or the next day, and bing, 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 it all happened. We have to address systemic issues. COVID has slowed stuff down. We now have doctors that are trained not to touch people unless they really have to. It's a complete craziness. But aside from that, the system itself is just, if it were in a swimming pool, it'd be drowning because it didn't have enough muscle and it weighed too much to get out of the pool in time to stop from drowning. There's efficiencies we could find, and there's no time in our time together to go through them, but we could list maybe 15 areas in which things could be streamlined and people could get the kind of care they need faster and better, and more efficiently and more effectively, rather, as well.
Good, thank you. Well, Dr. Snow, as a health professional, from your perspective, both from your own practice in Halifax and what you hear from folks right across the country, what's going on and what needs to be changed and what do we have to focus on to fix the obvious issues that have been outlined during the session so far?
Oh, wow, Bill. There's so much to do. If I had a wish list, I think I would put 3 things on it. First of all, as we've heard today, we need better healthcare systems for diagnosis. And that includes access to early diagnosis, of course, with screening programs, but also better access for those patients who have symptoms so they actually get diagnosed and onto treatment as quickly as possible. We need to recognize that lung cancer risk is highest in rural areas and among people who are less likely to be educated or more likely to be socioeconomically disadvantaged, and design programs that work for them first and foremost. Secondly, we need better access to the best treatments. John Peter talked a lot about getting access to treatments before they've even gone through the approval system in Canada, which is a very long process, which can literally take several years from the time that Health Canada approves a drug till it's actually funded by a province. But we also need to work to make sure that those drugs that are actually approved that we have access to them. That's a real problem in Eastern Canada. For instance, in Ontario and the Atlantic provinces, take-home cancer drugs like those targeted therapies we spoke about, even if they're approved by your province, they're not funded unless you're on the provincial drug coverage. So that leaves many patients who are less than 65 out in the cold and unable to access those life-saving treatments. And finally, I really think that ongoing campaigns and awareness to lift the stigma surrounding lung cancer are important. As Andrea mentioned, this has led to decreased funding for the #1 cancer killer in Canada gets a far smaller proportional piece of the pie. And that means that we aren't doing research on things like the impact of other risk factors for lung cancer, asbestos, pollution, the impact of a family history, and also on a day-to-day basis, the blame and shame that many of our patients are dealing with, they shouldn't have to. So I think awareness is really the way to go.
Great, thank you.
You and every Buddhist in the world.
Very good. We do have a few minutes left, and I think, Anthony, are there some questions that you would like to present on behalf of some of the folks who have talked to us on the chat?
There we go. Thanks, Bill. The first question that popped into my head was just to explain what those screening tests are. What's the difference between an X-ray, a CT, a CAT scan, MRI, just for the layman, or the PET scan? Can you just let us know what those are?
Absolutely. So I'll take that one. So a chest X-ray is a pretty simple image. You get kind of one image to the front to back, one image to the side of the lungs, and that's less sensitive. They've actually looked at that in terms of a screening tool for lung cancer, and it didn't actually lead to lung cancer lives saved. But it's the cheapest and the easiest to access. So it would have been nice if that had worked out. A CAT scan gives you much more detailed pictures, very, very precise pictures of the inside of the lungs. And it's almost like the body is sliced in different sections, and you can look through a series of, sometimes over 100 pictures that go millimeter by millimeter through the body. And that's really quite good at picking up very, very, very small nodules. A PET scan actually gives pictures that are not dissimilar to a CAT scan, but the pictures aren't as crisp. So I did answer that question in the chat why we don't use PET scans. The threshold of a PET scan is actually a centimeter to be able to say that something's cancer. The difference with a PET scan is that they inject a special glucose molecule that will glow in the image. And so if you've got a nodule and you don't know, is it scar tissue, for instance, like John Peter's wife may have had from childhood pneumonia, or is it an active cancer? If you get a PET scan, it will glow if it's cancer. It won't if it's a scar tissue. So it's really good at telling us if spots that we pick up, for instance, on a CT are cancer or not. Finally, an MRI, that's just another way of looking at the inside of the body. Again, lots of slices. MRIs are actually really good at looking at brains and looking at soft tissues, so joints and muscles, but they don't give us as nice pictures of lung cancer. We'll use them often for patients of lung cancer really up high in their lungs, where we want to see if it's invading ribs and the soft tissues in those areas. But a CAT scan really is our go-to for giving us the best pictures, for telling us information about lung cancer.
And related to that, then another question came in about postal code dictating the care you're able to get. How prevalent are CT scans in hospitals across Canada?
Well, it's not that hard to get a CT scan. It's all the part and parcel that goes with that. So, CAT scans used to be really tough to get. And there's still some areas of Canada where the wait list is very long, but they're usually available outside of the major centers, whereas a PET scan is usually in a major center. But it's the time from having an abnormal CAT scan to being referred to a specialist to have a biopsy. And then from there, having access to the molecular testing to look for a biomarker. And from then, the time and access to seeing a lung cancer specialist who can treat you for cure with radiation or surgery, or a medical oncologist like myself. And the other aspect of the postal code diagnosis, as I mentioned, there are many more prevalent cases of lung cancer in rural areas. And a lot of that has to do with occupational risks and exposures. And so we often see big things like lung cancer screening in big centers, but here in Nova Scotia, we're actually looking at a postal code basis. Where are most lung cancers being seen, and rolling out our programs? Our goal is in those areas first. So a lot of that will be, for instance, an area called Cape Breton, where there was a lot of coal mining. And so certainly we see a lot more lung cancer related to those exposures there.
And testing through blood tests or screening through blood tests, is that an option right now for lung cancers?
It's not here yet for lung cancer, but across many cancer types is really exciting research. And my dream is that, you know, in the future, that is exactly what you do. Your primary care provider will send your blood work to screen for breast cancer and prostate cancer and colon cancer and all of the cancers. And that technology is currently being developed. What we can do, however, with the blood right now for lung cancers, we can often pick up those targets and mutations. And so one of the really interesting potential solutions to the postal code issue is if somebody goes into their local small hospital with a cough or shortness of breath and gets a CAT scan done in their emergency room, and it's clearly a lung cancer and it's clearly advanced, if they could just have some blood drawn and shipped here to Halifax, we can run that molecular test. And if we find the target, we don't need to worry about getting a biopsy and having all those specialists. I can see that patient and get them on that targeted therapy right away. And so really, those blood-based targeted tests are very important for us to have access to.
And Bill, a question I think for you and John Peter and Andrea about advocacy. CARP comes as a large group voice in talking to policymakers and funders. Andrea, as a patient yourself, have to advocate on your own to your own doctors and caregivers. And John Peter, as a leader in a specific health or survivor group. So maybe Bill, question to you, how do we all work together to change the policies and the funding going forward?
This could be another whole webinar and probably should be, but the one thing that I would emphasize is we need the policymakers, not just the bureaucrats, the policymakers, to say this is important, this has to be done. And this will only happen if the policymakers, who are the elected politicians, know the people who vote for them individually are the people who want this to happen. So talk to your elected members of your provincial and your federal government and demand that they understand this topic and do something about it. If we all did that, if the 330,000 CARP members across the country did that, I could assure you the politicians would all sit up, take notice, and change would start to happen.
I would add to that we need to have a targeted message to the policymakers or to the politicians, that we go to them and say, we need this done in this area, this done in that area, so they know exactly where because they're going to go, most of them, to their bureaucrat, to the people that they're paid to serve them and give them opinions, and those opinions are already going to be stuck and ossified in the past. Or in the way, that's not the way we do things around here. People don't like change. So if you're going to tell people that you need change, you should tell them exactly where and how.
And Andrea, anything to add?
Yes, I agree. I've been involved in a lot of different advocacy work as well. But I want to just give you an example of why lung cancer screening is with us, because of advocacy as well as research studies which showed its value. But we wouldn't have it without individuals and organizations across Canada calling out for it for many years. And in BC in particular, it was the real impetus to get a provincial screening program was $1 million raised by a lung cancer patient and her family in British Columbia by the name of Shannon Gall. And I think that just demonstrates so much how getting engaged and working with the system to have these changes made can really make a difference.
Well, I hate to have to end this discussion, but we've had our hour, our time. There will be follow-up on this, and John Peter, your suggestion about having some specifics for people that they can talk to their politicians about, I think all of our organizations represent on this call, they can work together, and we can make that happen. And CARP will pledge to take a lead in making sure we all do that. So on behalf of everyone who's watching, I want to thank our three guests, Dr. Stephanie Snow, John Peter Bradford, and Andrea Redway. for sharing their experiences and perspectives on lung cancer in Canada. I also want to thank Merck Canada for supporting this webinar and remind everybody that it is being recorded, and everyone who registered will get a notice of when that is up. And you'll also find it on the CARP website. The CARP Facebook page is linked, and many other places. And I want to thank you, our audience, for taking the time to join us. We hope you found the discussion useful. It's important for all of us to get informed as much as possible about the health and healthcare of the system. More than ever, we need to take control of our own health by being informed and using the cancer screening services that are available. We also have to be active citizens, telling our politicians and telling our health leaders what's needed to ensure timely and quality cancer care is available to all Canadians. So thanks again for being with us, and have a great rest of your day.